Welcome to the Deep Dive, the show that cuts through the noise and gets straight to the core of what you need to know. Today, we're plunging into a topic that feels like it looms over every medical student, especially as you gear up for those big, comprehensive exams.
Yeah, that feeling.
Right. The sheer volume of complex physiological and pharmacological concepts you need to distill into, actionable clinical knowledge. Our deep dive today, the intricate world of hypertension.
That's right. And for you, our dedicated third-year medical student listener, our mission is pretty clear.
Okay.
We want to equip you with a really comprehensive, crystal clear, and most importantly, clinically relevant understanding of hypertension.
Okay.
We're going to untangle the fundamental mechanisms the body uses to control blood pressure, expose the complex ways hypertension develops, and frankly damages the body, and then, crucially, navigate the pharmacological strategies we use to fight back.
And we've meticulously pulled insights for this deep dive from detailed lecture transcripts. We're talking about, well, everything from the nuances of medium to long-term blood pressure control, the nitty-gritty details of how high blood pressure actually damages your tissues, and the precise management strategies, including the specific drug classes you'll eventually be prescribing. This isn't just about cramming for an exam. It's really about the fundamental why behind the what.
Exactly. Mastering this material goes far beyond just passing your exam. It's really the bedrock for understanding one of the most prevalent and impactful diseases you'll encounter in clinical practice.
It's everywhere.
It is. Hypertension isn't confined to a single organ. It touches and impacts nearly every system in the body. So this deep dive will give you that crucial framework, preparing you not just for recall, but for critical application at the bedside, building the foundation for, robust patient care.
All right, let's unpack this. We're starting with a fundamental question. Maybe sounds obvious, but one that's absolutely essential for laying our groundwork. Why does your body even need to control blood pressure so meticulously?
Good place to start.
Yeah. First and foremost, blood pressure is the driving force that regulates blood flow. Think of it as the delivery truck for every cell and tissue in your body, ensuring a constant supply of oxygen and nutrients. Without adequate pressure, that delivery just grinds to a halt and your tissues suffer.
And that ties directly into the second critical reason, preventing tissue damage.
What's truly insidious about sustained, abnormally high blood pressure is that it doesn't just slow things down, it actively causes a cascade of destructive processes.
Right.
We'll delve into this in more detail later, but for now, just remember that this damage accumulates silently over time, often without any immediate symptoms, making hypertension a true silent killer. So we've definitely discussed blood pressure control before, right? You'll probably recall the short-term mechanisms, those rapid responders that kick in literally within seconds to minutes after a blood pressure change.
The baroreflexes.
Exactly. These are primarily focused on swiftly adjusting vascular tone, meaning how much your blood vessels constrict or dilate, and fine-tuning cardiac output by tweaking heart rate and the heart's contractility, those immediate shock absorbers.
Precisely. But here's where it gets really interesting and where our focus is today. We're shifting gears to medium to long-term control. These mechanisms operate on a different time scale, coming into play over hours to days.
Okay.
And critically, their primary mechanism of action is fundamentally distinct from the rapid short-term adjustments. Instead of rapidly altering vascular tone or the heart's immediate pumping strength, these long-term systems primarily work by changing your blood volume.
Blood volume. Okay. And how exactly does changing blood volume translate into a change in blood pressure? It feels like a direct link, but spell it out.
It's a beautifully direct relationship, almost intuitive. If you increase your total blood volume, you're literally putting more fluid into your circulatory system. This increased volume means more blood fills the heart during diastole, right? Especially the ventricles before they contract. This greater filling volume stretches the heart muscle more, leading to an increased stroke volume. That's the amount of blood ejected with each beat. More stroke volume directly increases cardiac output.
Okay.
And with a higher cardiac output pumping into a relatively fixed, or at least responsive, vascular system, what do you inevitably see? An increase in blood pressure.
Right. Simple physics almost.
Exactly. And what's also fascinating is how increased blood volume amplifies local autoregulation. The additional blood flow actually stretches the arterioles, and this stretch, known as the myogenic response, triggers a local vasoconstriction. Yeah, this localized narrowing then increases resistance in those arterioles, contributing further to the overall increase in blood pressure. So when we talk about medium to long-term blood pressure regulation, Every pathway we discuss will ultimately circle back to the kidney's central and indispensable role in managing blood volume. It's the ultimate blood volume arbiter.
Okay, so the kidney is king here. But before we dive deep into the kidneys, let's take that quick detour you mentioned to capillary fluid shifts. I remember learning about this. You might think it's crucial for long-term control, but maybe not.
Right, it's worth touching on. You remember from basic physiology that fluid moves across capillaries due to a delicate balance of competing forces. Capillary hydrostatic pressure, which is essentially the pressure of the blood pushing fluid outwards, is the primary force that shoves fluid out of the capillary into the surrounding interstitial space.
Okay, pushes out.
And conversely, capillary oncotic pressure, largely driven by those big plasma proteins like albumin that can't easily cross the capillary wall, is the primary force keeping fluid within the capillary.
Pulls in.
Exactly. So hypothetically, if blood pressure increases, capillary hydrostatic pressure also rises, pushing more fluid out into the interstitium. This loss of fluid from the vascular compartment would decrease blood volume, theoretically lowering blood pressure.
And the opposite for low BP.
Right. The opposite would happen with low blood pressure. Less fluid out, blood volume retained, and BP would theoretically increase.
So why is this just a quick detour? Why isn't it the powerhouse for long-term blood pressure control like the kidneys are?
That's a great question, and it's important for your understanding. While capillary fluid shifts do influence blood volume, their capacity to adjust blood volume for sustained long-term regulation of blood pressure is quite limited.
Ah.
They only operate effectively over a very narrow range, and they simply can't handle the large, sustained changes necessary for truly managing blood pressure over hours or days. This brings us squarely back to the true champions of medium to long-term blood pressure control, the kidneys.
Ah, the kidneys. Truly, the undisputed arbiters of your body's fluid balance and, by extension, medium to long-term blood pressure regulation. These incredible organs are the main players in changing blood volume over prolonged periods.
Definitely.
To really grasp how they achieve this, we absolutely need a solid, concise refresher on their functional unit, the nephron.
Indeed. Understanding the nephron's anatomy is crucial for what's to come. Picture this. Blood enters the nephron via the afferent arteriole and flows into the glomerulus, which is this dense, tangled capillary network encased within Bowman's capsule.
The filter.
That's where the initial filtration of blood happens, separating a cell-free filtrate from the blood. From Bowman's capsule, this filtrate then embarks on a journey through a series of specialized tubules. First, the long, winding proximal convoluted tubule,
SET.
then the loop of Henle, followed by the distal convoluted tubule, and finally the collecting duct. This intricate plumbing allows for incredibly precise control over what substances, especially water and electrolytes, are reabsorbed back into the bloodstream versus what is destined to be excreted as urine.
Got it. Now, within this complex renal system, one master regulator orchestrates much of the long-term blood pressure control. The renin-angiotensin-aldosterone system, or RAAS. I remember hearing about this a lot.
You will?
At the very heart of this system are these specialized cells called juxtaglomerular, or JG cells. They're strategically located right where the afferent arteriole meets the distal tubule of the nephron, a critical anatomical placement. They're key because they secrete the enzyme renin directly into the bloodstream.
And the release of renin is incredibly finely tuned by several critical stimuli, something you'll definitely want to remember for your exams. Firstly, a decrease in arterial pressure, essentially low blood pressure, is a powerful stimulus for increased renin release. Think of it as the kidney sensing a lack of perfusion.
Okay, low pressure.
Secondly, decreased blood flow through the kidney, and specifically a low flow of sodium through the distal tubule, is detected by specialized cells within the juxtaglomerular apparatus called macula densa cells. These cells then signal the JG cells to release more renin.
Low sodium flow.
Right. And thirdly, if your blood pressure drops, the renal sympathetic nervous system is activated via renal baroreceptors, further prompting the JG cells to secrete more renin.
Oh.
So it's a multi-pronged alarm system that ramps up renin production.
Okay, so multiple triggers. And once renin is unleashed into the bloodstream, it kicks off a biochemical domino effect. Renin's job is to convert a protein called angiotensinogen, which is produced by your liver, into angiotensin I. Angiotensin then travels through the bloodstream, where it quickly encounters the angiotensin-converting enzyme, or ACE, found predominantly in the lungs. ACE then acts like molecular scissors, converting angiotensin first into its much more potent active form, angiotensin II.
Angiotensin II, this is the big one. It's critical for both short-term and long-term blood pressure regulation, and its actions are definitely high yield for your exams. As you might recall, it's a potent vasoconstrictor, rapidly narrowing blood vessels to increase pressure. That's short-term. But for our long-term discussion, its most significant action is triggering the release of aldosterone from the adrenal cortex. Aldosterone, in turn, is a major hormone specifically designed for controlling blood volume.
Okay.
So let's connect the dots. A drop in blood pressure or low sodium delivery to the kidney stimulates renin release. This leads to increased angiotensin II, which then stimulates aldosterone. The grand result is a significant increase in sodium and water reabsorption in the kidneys, leading to an increased blood volume, which ultimately brings blood pressure back up to normal levels. It's a powerful and tightly integrated feedback loop.
Makes sense. Beyond the RAAS, though, the kidney wields other powerful tools to manage blood volume. And one of the most significant involves the glomerular capillary hydrostatic pressure, or GCHP.
Ah, yes, GCHP.
Remember, the glomerulus is a unique capillary network because the fluid it filters isn't just lost into the surrounding tissue like elsewhere. It's filtered into the nephron, destined to become urine and eventually be excreted.
Right. Much more efficient way to lose volume if needed.
Exactly. This makes it an incredibly effective way to lose or retain blood volume, far more precise than general capillary fluid shifts. And arterial pressure, of course, plays a major role in dictating this GCHP.
This brings up a point that often trips students up, the autoregulation paradox. We've talked about how the kidney is remarkably adept at autoregulating its own blood flow, ensuring that the glomerular filtration rate, or GFR, remains relatively constant across a wide range of systemic arterial pressures.
Yeah, it tries to keep GFR stable.
It does. However, specific constrictions or dilations of the afferent and efferent arterioles can actually override this autoregulation to precisely influence GCHP and, by extension, GFR.
Think about simple fluid dynamics. Constricting a vessel increases the pressure upstream of the constriction and decreases it downstream. Dilation does the opposite.
Okay, so the kidney can fine-tune GFR despite the overall pressure. Let's break down these factors influencing GCHP, because this feels detailed but important. It is. When there's sympathetic nervous system activation, coupled with noradrenaline and angiotensin II release, you get constriction of the afferent arteriole. That's the incoming vessel to the glomerulus.
Tighten the inflow.
Exactly. Now, if you tighten that incoming hose, the pressure before the glomerulus increases, but the pressure within the glomerulus itself, the GCHP, decreases.
Ah, okay.
A decreased GCHP means less fluid filtration, less fluid loss into the urine, which then increases overall blood volume and helps bring blood pressure back up.
Makes sense. And the opposite.
Conversely, if your blood pressure is very high, substances like acetylcholine from the parasympathetic system or dopamine can cause afferent arteriolar dilation. This increases GCHP, boosts GFR, leads to more fluid loss, and ultimately decreases blood volume and blood pressure.
Okay, afferent control is key.
It is, and it gets even more intricate, showing the body's sophisticated control. While noradrenaline and angiotensin II generally constrict the afferent arteriole at very high concentrations, angiotensin II will also powerfully constrict the efferent arteriole, the vessel leaving the glomerulus.
Okay, the outflow pipe gets tightened too.
Right. Constricting the efferent arteriole creates a bottleneck, which effectively backs up blood and increases the pressure upstream in the glomerulus itself, thereby increasing GCHP and, initially, GFR.
Ah, so high Ang2 can actually boost GFR initially.
Initially, yes. But as we'll soon see, the story doesn't end there thanks to other compensatory mechanisms in the proximal tubule. What's also fascinating here is the often overlooked role of mesangial cells. These are specialized cells nestled within the gaps of the glomerular capillaries, and they're also connected to Bowman's castle.
Mesangial cells. Okay.
When they contract, primarily in response to noradrenaline and angiotensin II, they physically decrease the total surface area available for filtration, thereby reducing GFR and fluid loss. This further contributes to increasing blood volume. It's a comprehensive squeeze on filtration.
Wow. Okay, so multiple layers of control just at the glomerulus. Now, building on that, let's talk about the proximal tubule paratubular capillary hydrostatic pressure. That's a mouthful, but sounds important.
It is, and a clinically critical concept. This refers to the pressure in the capillaries that surround the proximal tubule, where the vast majority of reabsorption of filtered substances occurs.
Okay.
You just explained how high concentrations of angiotensin II constrict the efferent arteriole, increasing GCHP upstream. But here's the crucial nuance. That same efferent constriction decreases the hydrostatic pressure in the paratubular capillaries downstream from the glomerulus.
So Pressure drops after the efferent pinch point.
Precisely. And this is a truly vital takeaway for your exams and for understanding how the body compensates. The decreased hydrostatic pressure in the peritubular capillaries creates a more favorable gradient, making it easier for electrolytes like sodium and water to be reabsorbed from the proximal tubule back into the blood.
So lower pressure outside the tubule helps suck stuff back in.
Exactly. In essence, by reducing the outward pressure against which reabsorption has to work, you significantly increase the reabsorption of sodium and, as water always follows, a massive amount of water. So despite angiotensin II potentially increasing GFR initially, the incredibly efficient reabsorption happening downstream in the proximal tubule effectively retains blood volume, ultimately helping to restore blood pressure back to normal. It's a powerful, almost counterintuitive compensatory mechanism that ensures fluid retention.
That's a key detail. So how does that electrolyte and water reabsorption actually happen at the nitty-gritty cellular level in the proximal tubule?
Good question. On the luminal surface of these tubular cells, the side facing the fluid, you have a sodium-hydrogen exchanger, an active transport mechanism. And then on the peritubular capillary membrane, the side facing the blood, you have the ubiquitous sodium-potassium ATPase.
The workhorse pump.
Right. Sodium is actively reabsorbed from the tubular fluid back into the blood via these mechanisms. And crucially, wherever sodium goes, water follows, almost like a magnet, due to osmosis. Plus, other osmolytes like glucose are also reabsorbed along with sodium, further pulling water back into the bloodstream.
And this gets ramped up when BP is low.
Exactly. What's truly remarkable here is how this entire reabsorption process is greatly enhanced in conditions of low blood pressure. Low blood pressure leads to increased sympathetic activation, which then results in the release of noradrenaline and, as we've discussed, angiotensin II.
Right.
Both of these substances, noradrenaline and angiotensin II, bind to their respective receptors on the tubular cells. This binding dramatically enhances the activity of these ATPases, vigorously promoting sodium, osmolyte, and water reabsorption. This effectively pulls more fluid back into the bloodstream, diligently returning blood volume and, by extension, blood pressure back to normal. It's an elegant, integrated system.
Okay, PCT is huge for reabsorption. Now, let's turn our attention to aldosterone, a hormone we've mentioned as a key player in the RAS pathway. What's its specific role again?
Aldosterone's primary action is to significantly increase water reabsorption, but it specifically focuses its efforts on the distal tubule and the collecting duct of the nephron.
Later parts of the tubule.
Correct. By doing so, it directly increases blood volume and, consequently, plays a major role in bringing blood pressure back to normal.
And mechanism.
The mechanism here is quite specific. Aldosterone, released in response to low BP via sympathetic activation in the renin-angiotensin II pathway, travels to the kidneys and binds to its specific mineralocorticoid receptors on the cells of the distal tubule and collecting duct.
Binds to receptors.
This binding has a profound effect. It increases the number and activity of sodium channels on the luminal surface of these cells, and it also boosts the activity of the sodium-potassium ATPase pump on the capillary surface.
More sodium pumps and channels.
Yes. The combined effect is a massive enhancement of sodium reabsorption, and as we know, water eagerly follows sodium due to the osmotic gradient. This dramatically increases blood volume, diligently restoring blood pressure to normal.
Got it. Aldosterone is distal sodium and water retention. Now, working hand in hand with aldosterone, we have another crucial player in water retention, antidiuretic hormone, or ADH, also known as vasopressin.
ADH, yes, very important.
ADH is released from the posterior pituitary gland, primarily triggered by a decrease in overall blood volume or a rise in plasma osmolarity, essentially, when your blood becomes too concentrated.
Right, dehydration or low volume. And its action is both straightforward and powerful. ADH also increases water reabsorption, specifically in the distal tubule and the collecting duct, same place aldosterone acts, but different mechanism.
Okay, how does ADH do it?
It achieves this by causing the insertion of specialized water channels called aquaporins into the membranes of these tubular cells.
Aquaporins. Water pores.
Exactly. The presence of these aquaporins dramatically enhances the permeability of these tubules to water, allowing more water to be reabsorbed from the filtrate back into the blood. This directly increases blood volume and, as a result, helps restore blood pressure.
So ADH makes the pipes leakier to water, specifically.
In a regulated way, yes, makes them more permeable.
Okay. So when we pull back and look at the big picture, What does this all mean for you as a medical student trying to grasp this? It means the body has this incredibly robust, integrated system designed to compensate for any changes in blood volume and pressure, working tirelessly to maintain that crucial balance.
Exactly. Let's try to summarize the body's integrated compensatory responses with a concise flowchart, because this holistic understanding is vital for your exams. In response to either a low blood volume, a dip in blood pressure, or a low amount of sodium reaching the distal tubule of the nephron, what happens first?
Renin release increases.
Perfect. Your body triggers an increase in renin secretion. This, in turn, leads to the formation of angiotensin II and subsequently aldosterone. The combined action of angiotensin II and aldosterone is to significantly increase sodium and water reabsorption in the nephron, effectively bringing blood volume and blood pressure back to normal.
Okay, RES handles that.
Simultaneously, a low blood volume or an increase in plasma osmolarity triggers the release of antidiuretic hormone, or ADH. ADH then increases water reabsorption within the nephron, again diligently working to normalize blood volume and blood pressure. These systems are not isolated, they work in concert, providing multiple layers of defense to maintain vital homeostasis.
Got it. RES and ADH working together to keep volume and pressure steady. Okay, we've meticulously laid out the body's sophisticated defense mechanisms for maintaining blood pressure. But here's where it gets really challenging and clinically crucial. What happens when these finely tuned mechanisms designed to protect us actually go awry?
Yeah, this is the crux of primary hypertension.
This is the unfortunate reality of primary systemic hypertension. Many of the very same systems that are supposed to normalize blood pressure become dysfunctional in hypertension, actively contributing to the disease and creating a truly vicious cycle.
It's a profound shift, almost a betrayal of normal physiology. A number of proposed physiological, neurohumoral, and cellular changes are consistently observed in primary hypertension. We frequently see an abnormally increased release of angiotensinogen and aldosterone, particularly relative to renin levels, suggesting a deep dysregulation within the RAS.
So the balance is off.
Right. There are also altered renal tubular mechanisms, meaning that despite the blood pressure being high, the kidneys paradoxically retain more fluid, further increasing volume and pressure. Changes in plasma and intracellular calcium ion concentrations can directly influence vascular tone, leading to chronic vasoconstriction.
And it's not just fluid and calcium. There's also often increased sympathetic nervous system activity, essentially keeping the body in a constant state of fight or flight, which contributes to elevated heart rate and vasoconstriction.
On top of that, there's a decreased vascular response to beta-2 adrenergic vasodilation, meaning the blood vessels that should relax don't respond adequately. We also see alterations in G protein activity, which are linked to beta-adrenergic effects, potentially increasing stroke volume and contractility. And a major player is endothelial dysfunction, a reduced release of the crucial vasodilator nitric oxide, coupled with an increased release of the vasoconstrictor endothelin.
Wow, so it's like everything is conspiring.
Exactly. You can see how all these proposed abnormal changes conspire to either cause, maintain, or worsen hypertension, creating a complex, multifaceted problem.
This complex interplay leads to what we critically refer to as the vicious cycle of hypertension. Can you explain that cycle?
Yeah, it's key. You have high blood pressure, yet the body's regulatory systems are dysfunctional. This paradoxically leads to increased renin secretion, which in turn fuels more angiotensin II and aldosterone.
Even though pressure is already high.
Exactly. This cascade then promotes even more sodium and water reabsorption, further increasing blood volume and driving blood pressure even higher. It's a self-perpetuating, reinforcing loop that escalates the problem, emphasizing why external intervention is so critical.
So drugs are needed to break the cycle.
Precisely. For your exam, think about how each class of antihypertensive drug like renin inhibitors, ACE inhibitors, ARBs, aldosterone receptor blockers, and various diuretics is designed to interrupt specific points in this dysfunctional cycle, either by reducing fluid retention or promoting diuresis, thereby breaking the cycle.
With that in mind, let's talk about the truly devastating ultimate consequence of uncontrolled hypertension: cardiovascular disease. It's a sobering statistic that CVD, encompassing strokes, heart failure, renal failure, myocardial infarction, and peripheral vascular disease, is the leading cause of death in people over 45.
It is. And hypertension isn't just a risk factor. It's a key, if not the key, driver due to the profound, long-standing damage it inflicts on your body.
So how does it do that damage?
Indeed. To simplify a complex process for your understanding, we've identified 5 key integrated mechanisms linking hypertension-induced vascular damage to these devastating target organ changes. Firstly, it chronically increases myocardial oxygen demand relative to its supply.
Okay, heart works harder with less fuel.
Second, it directly promotes cardiomyocyte damage. That's your heart muscle cells dying. Thirdly, it actively promotes the formation of atherosclerotic lesions, the plaques.
Atherosclerosis, right.
Fourthly, it contributes to arteriosclerosis, the hardening of the arteries. And finally, it damages the crucial resistance vessels, the arterioles.
And you mentioned something overarching.
Yes, acting as a crucial overarching mechanism mediating much of this vascular damage is oxidative stress. We'll come back to that.
Okay, 5 mechanisms plus oxidative stress. Let's unpack the first one. How hypertension throws off the myocardial oxygen demand to supply ratio. Normal heart, demand meets supply. Hypertension messes this up.
Right. Here's how this imbalance unfolds. Firstly, the heart is forced to work against abnormally high pressures in the vasculature, meaning there's a chronic, increased afterload on the left ventricle.
More resistance to pump against.
Exactly. According to Laplace's law, an increase in afterload directly leads to an increase in myocardial oxygen consumption, thus escalating demand. The heart attempts to compensate for this chronic overload by undergoing what's called concentric hypertrophy. The wall of the left ventricle thickens in an attempt to normalize wall tension and reduce that afterload.
Gets thicker to handle the pressure. Seems adaptive.
Initially, maybe. But this compensatory mechanism has a crucial detrimental consequence you need to grasp. The coronary arteries, which deliver blood to the heart muscle, are located on the external surface of the heart.
Right on the outside.
As the ventricular wall thickens and gets bulkier, the blood supply to the inner subendocardial surface is significantly reduced, leading to subendocardial myocardial ischemia. This is precisely why hypertension is such a major risk factor for ischemic heart disease.
Ah, the inside layer gets starved.
Exactly. Furthermore, hypertension also causes blood vessel changes, like decreased angiogenesis, remodeling, and endothelial dysfunction, all leading to narrower, more constricted vessels, decreased blood flow, and ultimately a decreased oxygen supply to all tissues, exacerbating the problem.
Wow, okay. Building on that damage to the heart's workload, let's discuss the second mechanism, direct cardiomyocyte damage. Long-term hypertension isn't just about increased workload. It actively causes heart muscle cell death through apoptosis and necrosis.
Yeah, the cells themselves suffer. This cell death is primarily mediated by the chronically increased angiotensin II and noradrenaline levels seen in hypertension, along with the pervasive oxidative stress we'll detail shortly.
And the consequences of these cells dying.
The consequences are profound.
Yeah.
You get myocyte slippage, where heart muscle cells literally separate from each other after death, and a significant disruption to the collagen scaffolding that normally holds the cardiac myocytes together, leading to less cross-linking and poor structural integrity.
The structure falls apart.
Pretty much. This structural breakdown leads to pathological cardiac remodeling, where the heart becomes big and dilated. Clinically, a large dilated heart often signifies systolic dysfunction, meaning it struggles to generate an effective force of contraction and pump blood efficiently. It's no longer the strong, efficient pump it once was.
Okay, damaged pump. Moving to the vessels themselves, the third mechanism is how hypertension actively promotes atherosclerosis. It's not just a bystander, it drives plaque formation.
Absolutely. Hypertension directly contributes to almost every step of this insidious process, initiating and accelerating plaque formation. It causes endothelial injury, making the delicate lining of your blood vessels more permeable,
Leaky lining.
which then allows dangerous LDL cholesterol and inflammatory monocytes to sneak into the vessel wall. It also amps up oxidative stress, leading to the damaging oxidation of LDL cholesterol. There's increased inflammation, encouraging monocytes to transform into macrophages that then engulf this oxidized LDL, forming those telltale foam cells that are the precursors to the lipid core of the plaque.
Foam cells, the start of the plaque.
Right. Hypertension also promotes smooth muscle proliferation and migration from the media, the middle layer of the vessel, into the intima, where these migrated cells then transform into fibroblasts and churn out collagen, forming the fibrous cap of the plaque. Plus, it increases platelet aggregation and activates matrix metalloproteinases, which are enzymes that can degrade collagen and lead to dangerous plaque rupture.
So it fuels the whole process. Can you walk us through the steps again, just for clarity?
Sure, it's crucial. It all begins with LDL cholesterol particles and monocytes circulating in the blood lumen. Due to endothelial injury, which hypertension significantly exacerbates, the vessel wall becomes more permeable, allowing these LDL particles and monocytes to penetrate into the intima.
They get in.
Once inside, the LDL cholesterol becomes oxidized, a process greatly amplified by hypertension-induced oxidative stress, and monocytes transform into macrophages. These macrophages then ravenously engulf the oxidized LDL, becoming foam cells, which look foamy under a microscope due to their lipid content.
Okay, foam cells form.
As foam cells accumulate and eventually die, they release their lipid content, forming a necrotic lipid core. Simultaneously, from the media layer, smooth muscle cells proliferate and migrate into the intima. Here, they transform into fibroblasts and begin synthesizing large amounts of collagen, forming a fibrous cap over the lipid core.
Cap covers the goo.
Essentially. This growing plaque bulges into the vessel lumen, and critically, it can damage the overlying endothelial membrane, creating rupture points where platelets can adhere and form a thrombus. What's truly critical here is that hypertension contributes directly to each and every one of these steps, from the initial endothelial injury to the final plaque complications. It turns what might start as a small protrusion into a potentially completely occluded vessel, leading to heart attacks or strokes.
Got it. Hypertension drives atherosclerosis at every stage. Now for the fourth mechanism, the promotion of arteriosclerosis, specifically affecting the aorta and other large elastic arteries. This is the hardening of the arteries, distinct from atherosclerosis, right?
Correct, though they often coexist. In arteriosclerosis, hypertension triggers a series of profound structural changes. It increases wall tension, longitudinal shear stress, and pulsatile stress within these large vessels. This chronic stress leads to the breakdown and fragmentation of the elastic lamina, the very structure that gives these arteries their crucial elasticity.
Loses its stretchiness.
Exactly. The vessel then undergoes maladaptive remodeling, characterized by a fundamental shift in its composition. An increase in stiff, smooth muscle cells and collagen, critically coupled with a decrease in elastic tissue and an unhealthy increase in calcium deposition within the wall. Furthermore, hypertension causes endothelial damage, leading to decreased production of the vital vasodilator nitric oxide.
So it becomes stiff and less responsive.
Right. Diagrammatically, what this means is that the normal, highly elastic aorta, designed to expand and recoil with each heartbeat, transforms into a stiff, rigid pipe. The lumen radius often decreases, and wall thickness increases. The wall becomes far less elastic, replaced by rigid collagen and smooth muscle. This remodeling, combined with reduced NO-mediated vasodilation, dramatically increases the impedance, or ZC, which is the resistance in a pulsatile system, in these large vessels.
Higher resistance in the big pipes.
Which leads to a significant increase in systolic blood pressure and consequently a widened pulse pressure. Because of the loss of elastic recoil, the diastolic blood pressure often remains normal or even decreases. This clinical presentation, where systolic BP is elevated, greater than 140 mV/Hg, but diastolic BP is normal or low, less than 90 mV/Hg, with a pulse pressure greater than 50 mmHg, is termed isolated systolic hypertension, or ISH, and it's a significant independently dangerous risk factor you must recognize.
ISH. Got it. Important distinction. Moving from the large arteries to the smaller yet equally vital resistance vessels, let's look at the fifth mechanism, damage to the arterioles. These tiny vessels control resistance, and hypertension hits them hard too.
It does. Again, hypertension significantly increases vessel wall tension, longitudinal stress, and pulsatile stress in these arterioles. It also drives profound vascular remodeling here. But here's a key distinction from large arteries. In arterioles, this remodeling leads to a decrease in smooth muscle cells and a disproportionate increase in collagen, ultimately making them stiff and less able to dilate.
Different remodeling pattern in small vessels.
Yes, more collagen, less smooth muscle. Like elsewhere, endothelial damage is present, reducing nitric oxide production. The consequences are profound. This remodeling, driven by both hemodynamic factors like flow and pressure, and neurohumoral factors such as angiotensin II and oxidative stress, leads to increased arteriolar wall thickness and a decreased radius. This, combined with endothelial dysfunction leading to less NO and more endothelin-induced vasoconstriction, results in a significantly increased systemic vascular resistance, directly contributing to chronically elevated blood pressure.
And we can see this damage.
Clinically, yes. You can often identify this damage by examining the retinal blood vessels. Hypertensive retinopathy manifests as microaneurysms, hemorrhages, exudates, collections of leaked protein and lipids, and in severe cases, papilledema, swelling of the optic disc. These changes are graded by severity and are a direct visual sign of systemic arteriolar damage, especially crucial for your exams.
Look in the eye. See the systemic damage. Okay, so we've talked about a lot of damaging mechanisms, but there's one crucial common thread running through almost all of them: Oxidative stress. You mentioned this earlier.
Yes, oxidative stress is the silent culprit, the common link. Let's define it clearly. In a healthy endothelium, the amino acid L-arginine is converted into nitric oxide, or NO, by an enzyme called NO synthase. NO is a potent vasodilator, essential for keeping blood vessels relaxed and healthy.
The good guy, NO.
Right. However, in hypertension, due to pathologically elevated RAAS activity, high orelinarin levels, and various inflammatory cytokines, this normal pathway is fundamentally hijacked. Instead of producing beneficial NO, NO is actually consumed or converted into highly reactive oxygen-free radicals like superoxide, hydrogen peroxide, and peroxynitrite.
So NO gets turned into bad guys?
Essentially, yes. This means that NO, the crucial vasodilator, is effectively no longer available to do its job because it's been transformed into these damaging free radicals.
And what exactly do these oxygen-free radicals, this oxidative stress, do to our vessels? How does it contribute to the overall damage?
They are incredibly destructive, mediating much of the long-term damage. They actively promote both atherosclerosis and arteriosclerosis. They mediate decreases in the crucial elastic protein elastin, increases in stiff collagen, increases in smooth muscle proliferation, and significant decreases in overall endothelial function. The net result is a decrease in the radius of blood vessels and increased vasoconstriction, which directly drives up blood pressure.
So it worsens stiffness and constriction.
Precisely. What's interesting from a pharmacological perspective is that ACE inhibitors can partially intervene here. By reducing angiotensin II formation, they indirectly reduce oxidative stress and can even promote NO production through bradykinin, though this mechanism is also responsible for the common side effect of a dry cough with ACE inhibitors.
The ACE cough connection.
Right. Additionally, these oxygen-free radicals trigger other detrimental processes. Upregulation of adhesion molecules, making it easier for inflammatory cells to stick to vessel walls, increased production of cytokines and monocyte chemotactic proteins, recruiting more inflammatory cells, increased plasminogen activator inhibitor 1, promoting thrombus formation, increased growth factors, driving smooth muscle cell growth, and activation of MMPs, which can degrade collagen and lead to plaque complications.
It's a cascade of badness.
It really is. The overall message here is crucial for medical students. These structural vascular changes are not just passive consequences. They maintain high blood pressure, creating a reinforcing vicious loop. This is why early and aggressive intervention is absolutely critical, not only to treat the hypertension, but to prevent these irreversible structural changes from taking hold and perpetuating the disease.
Stop the remodeling before it starts, or at least slow it down. Now, let's consider a profound hemodynamic consequence of this widespread vascular remodeling, a concept called impedance matching. What's that about?
Okay, this is interesting. In a healthy circulatory system, there's a natural impedance mismatch, a difference in resistance that's actually beneficial. The aorta, being a very large and highly elastic vessel, naturally has a very low impedance or resistance to blood flow.
Easy flow in the aorta.
Right. In stark contrast, peripheral arteries, like the carotid, have much smaller lumens and are far less elastic, resulting in a naturally very high impedance. This mismatch is absolutely vital because it ensures that the high pressures and flows generated by the heart remain primarily within the central aorta, with much lower, dampened pressures and flows transmitted to the delicate peripheral vessels, protecting them.
So the mismatch protects the smaller vessels.
Exactly. What's truly fascinating and problematic with vascular remodeling in hypertension is that this healthy impedance mismatch is lost. The aorta, due to arteriosclerosis, loses its elasticity, its walls thicken, and its lumen can even become smaller. Consequently, its characteristic impedance dramatically increases.
Aorta becomes high resistance too.
Which leads to a state of impedance matching, where the impedances between the central aorta and the peripheral arteries become surprisingly similar. The critical consequence is that the high pressures and high flows, instead of being dampened, are now directly transmitted into peripheral vessels like the carotid and those in the brain and kidneys. This results in increased pulsatile flow and, crucially, chronic pulsatile damage in these distal sensitive vessels.
Hammering the small vessels with high-pressure pulses.
Precisely. Both the brain and the kidneys are particularly susceptible to this pulsatile damage, leading to devastating clinical outcomes like strokes in the brain and renal failure in the kidneys. It's a fundamental shift in hemodynamics that you should understand.
Wow. Okay, so to summarize the devastating consequences of chronic, uncontrolled hypertension. It increases myocardial oxygen demand relative to supply, promotes direct damage to heart muscle cells, accelerates the formation of dangerous atherosclerotic lesions, drives the hardening of the large arteries known as arteriosclerosis, and damages the crucial resistance vessels, the arterioles.
By these 5 integrated mechanisms, which are largely mediated by oxidative stress, hypertension leads to widespread damage across critical organs.
Yeah.
It damages the heart, the coronary blood vessels, large arteries, arterioles, and the delicate renal microvasculature. Ultimately, this sustained silent damage culminates in major cardiovascular diseases and events, including strokes, heart failure, renal failure, myocardial infarction, and peripheral vascular disease.
Yeah.
Understanding this comprehensive picture of pathology is fundamental to appreciating the urgency and necessity of effective hypertension management. It drives home why what we're about to discuss, treatment, is so vital.
Absolutely. So with that rather sobering picture of hypertension's insidious impact now clearly in mind, let's pivot to how we fight back. When we look at the general principles of antihypertensive therapy, you'll find that most of these drugs primarily work by changing total peripheral resistance.
Right, TPR is key.
Essentially, they aim to decrease the diameter or radius of the resistance vessels, thereby reducing the sheer pressure the heart has to overcome to pump blood.
Indeed. Many of these pharmacological agents directly target the physiological mechanisms we've just discussed, whether it's diuretics to reduce blood volume or drugs that block the renin-angiotensin-aldosterone system. Historically, the focus of treatment was primarily on lowering diastolic blood pressure. However, what's a critical shift in modern cardiology, and something to remember for your exams, is the recognition of the paramount importance of systolic blood pressure, regardless of age. We now emphasize that a normal BP should still be 10 to 80 millimeters Hg, even in the elderly.
Systolic matters, even if diastolic is okay.
Absolutely. Epidemiological studies have starkly shown that starting from a baseline of 1,100 and 575 millimeter Hg, for every 2010 millimeter Hg increase in blood pressure, there's a doubling in cardiovascular disease risk. This truly underscores the fundamental importance of treating high blood pressure, as it significantly reduces both mortality and morbidity. It's not just about feeling better, it's about life and death.
That's a stark reminder of the stakes, and for your patients, it's about their future. Beyond the numbers, it's also about managing modifiable risk factors, the ones we can change.
Critical point.
We're talking about blood pressure itself, of course, but also cholesterol levels, especially the total cholesterol to HDL ratio. And perhaps surprisingly, cigarette smoking. When combined with high cholesterol and high blood pressure, it can increase cardiovascular risk by over 80%.
Huge multiplier.
Type 2 diabetes mellitus is also a huge one. It's considered a cardiovascular risk equivalent, meaning a patient with type 2 DM is assumed to have the same risk as someone who has already had a myocardial infarction or stroke.
Other critical modifiable risk factors include diet emphasizing fresh fruits and vegetables, especially leafy greens like spinach and broccoli, and reducing fat intake. Lack of regular exercise, any form of renal damage leading to diminished glomerular filtration rates, type 1 diabetes with microalbuminuria, a sign of early kidney damage, obesity, and low HDL cholesterol levels are all significant contributors to overall cardiovascular risk.
Lots to work on potentially.
And on the non-modifiable side, factors like C-reactive protein, a marker of inflammation, age, men over 45, women over 55, or with premature menopause, elevated uric acid, disturbances in fibrinolytic and platelet activity, and of course, family history and genetics for coronary artery disease all play a role. Understanding these helps you build a holistic patient profile.
When we connect this back to the core physiology, remember the fundamental pressure-flow resistance relationship. Arterial pressure, or MAP, essentially equals cardiac output multiplied by total peripheral resistance.
MAP equals COX TPR. Basic but essential.
Remember, MAP also approximates diastolic BP plus 1/3 of the pulse pressure. The key insight for treating hypertension lies in targeting total peripheral resistance, which, thanks to Poiseuille's law, is overwhelmingly influenced by the radius of the blood vessel specifically, as 1 over the radius to the 4th power.
Radius to the 4th power, that's huge leverage.
Exactly. This mathematical relationship means even tiny changes in vessel radius lead to massive exponential changes in TPR.
So this is why vasodilators are so incredibly effective. They cause small changes in the caliber of resistance vessels, but result in huge, clinically significant changes in resistance. The sympathetic nervous system, releasing noradrenaline that acts on alpha-1 receptors and angiotensin II, which, remarkably, is about 40 times more potent than noradrenaline as a vasoconstrictor, are major drivers of chronic vasoconstriction.
Wow, 40 times.
Yeah. Therefore, blocking these pathways effectively reduces TPR and consequently blood pressure. While beta blockers can reduce cardiac output by lowering heart rate, our primary treatment target in hypertension is generally TPR. We usually want to avoid significantly dropping CO, especially in patients who might have underlying cardiac issues, to avoid potentially inducing heart failure.
Target the resistance, not usually the pump. And the benefits of achieving these treatment targets are truly profound for target organ protection, something that will directly impact your patients' lives.
Absolutely. Treating hypertension drastically reduces the risk of retinopathy in the eyes, both hemorrhagic and thromboembolic strokes in the brain, end-stage renal disease, left ventricular hypertrophy, and a remarkable 50% reduction in heart failure. It also significantly reduces the risk of myocardial infarction.
Huge benefits across the board.
What's even more compelling for you as future clinicians is that these benefits are seen across all ages, particularly in the elderly, dispelling any previous notions that treatment wasn't as effective in older populations.
Good to know. Treat everyone who needs it. This brings us to a specific condition you'll definitely encounter. Isolated systolic hypertension, or ISH. Remind us what that is again.
Right, ISH. This is defined as a systolic blood pressure greater than 140 mmHg, a diastolic blood pressure less than 90 mmHg, and consequently a pulse pressure greater than 50 mmHg. Historically, it wasn't always considered as critical to treat as combined hypertension, but we now know unequivocally that it is a significant independent risk factor for cardiovascular events and benefits immensely from aggressive treatment across all age groups. This is a common exam question, so make sure you understand it.
Treat ISH aggressively. Got it. So, given all that, which tools do we have in our vast pharmacological arsenal? The first-line classes, which we'll briefly overview now before diving deeper,
Okay, the main players.
include diuretics, particularly the thiazide-like diuretics such as hydrochlorothiazide and indapamide. Then we have the RAR inhibitors covering ACE inhibitors, angiotensin receptor blockers or ARBs, and aldosterone receptor blockers like spironolactone. Calcium channel blockers, or CCBs, are another major class. And finally, direct nitric oxide donors like hydralazine and sodium nitroprusside, often reserved for more acute or severe cases.
Good overview. Let's dig into those.
Let's kick off our deep dive into the specific drug classes with calcium channel blockers, or CCBs. Their mechanism of action is elegant and highly effective, making them a cornerstone of hypertension management.
Definitely a go-to class.
They work by inhibiting the entry of calcium ions into L-type calcium channels, which are primarily found in vascular smooth muscle cells, or VSMCs. These cells are almost entirely dependent on external calcium for their contraction, making them highly susceptible to CCB action.
What's fascinating here and important for your foundational understanding is the precise molecular cascade that CCBs interrupt. When calcium does enter the VSMC through these L-type channels, it immediately binds to a protein called calmodulin.
Calcium binds calmodulin.
This calcium calmodulin complex then activates an enzyme called myosin light chain kinase. Myosin light chain kinase, in turn, phosphorylates myosin light chain. It's this phosphorylation that enables myosin light chain to bind to actin, ultimately leading to VSMC contraction and vasoconstriction.
So calcium entry phosphorylation contraction.
Exactly. So by preventing that initial calcium entry, CCBs effectively short-circuit this entire phosphorylation pathway, causing the VSMCs to relax. This relaxation leads to vasodilation, a significant decrease in total peripheral resistance, and consequently, a robust drop in blood pressure.
Nice and clean mechanism.
Mhm.
What are the big advantages of this group of drugs for our patients?
Well, they're incredibly sensitive, meaning you need relatively low concentrations to effectively block those voltage-gated L-type calcium channels. They're also highly calcium-specific, avoiding unwanted interference with other ion channels. Crucially for hypertension management, they generally don't cause sodium and water retention, which could be a problem with some other antihypertensives.
Good point.
And they don't commonly cause postural hypotension, unlike some alpha-1 blockers. So they're very good at causing vasodilation without some of those challenging common side effects.
Okay. Now, CCBs aren't all the same, right? There are types.
Correct. CCBs are broadly divided into two main types, a distinction that's vital for clinical application in your exams. First, the dihydropyridines, such as nifedipine and amlodipine, these are primarily vascular selective.
DHP's vascular.
Mostly. At therapeutic concentrations, they predominantly act on vascular smooth muscle cells to cause vasodilation, with a largely neutral effect on the heart itself. This means they don't directly impact heart rate or contractility, unless used at very high, often supratherapeutic concentrations. However, nifedipine, especially in its short-acting formulation, has some specific issues you must be aware of.
Ah, the short-acting nifedipine issue.
Yeah, its very short half-life and rapid onset of action can cause a sudden dramatic drop in blood pressure. This rapid drop can then trigger a reflex tachycardia, a compensatory increase in heart rate. This reflex tachycardia is problematic because it shortens diastolic filling time and can compromise blood flow to the heart, potentially worsening ischemia in certain patients.
Not good.
Definitely not. Therefore, for hypertension, nifedipine is almost exclusively used in long-acting preparations to ensure a slow, sustained release and avoid these acute sympathetic activations. Amlodipine, on the other hand, is a more modern DHP with a much slower onset, metabolism, and excretion, so it doesn't require a slow-release formulation and is generally better tolerated.
Okay, so long-acting DHP is generally preferred. Then we have the other group, the non-dihydropyridines, primarily verapamil and diltiazem. What's different about them?
The major difference here, and the core clinical distinction, is their dual action. While they also block calcium channels in VSMCs and cause a similar blood pressure drop as the dihydropyridines, at therapeutic concentrations, they also act directly on the heart itself.
Non-DHPs, vascular and cardiac.
Exactly. Their cardiac effects are clinically significant and form the basis of some of their unique uses. They block calcium entry into the SA node and AV node, which are critical for regulating heart rate and AV nodal conduction. This means they can decrease heart rate and block AV nodal conduction, making them clinically useful for certain arrhythmias, like atrial tachycardias, atrial fibrillations, and atrial flutters, where slowing ventricular rate is key.
Ah, so they have antiarrhythmic uses.
Yes. Additionally, they can sometimes drop stroke volume by interfering with calcium uptake into sarcomeres, which is essential for myocardial contractility. So for your exam, remember, both types of CCBs effectively reduce total peripheral resistance through vascular effects, but non-dihydropyridines also have direct, often therapeutic effects on cardiac electrical activity and contractility.
Got it. So when we look at the broad clinical uses for calcium channel blockers, they are mainly used today as highly effective antihypertensives because they're so good at dropping total peripheral resistance. But they're also very useful in angina, providing symptomatic relief.
Right. Reducing afterload helps angina.
And as you mentioned, the non-dihydropyridines are specifically used for certain arrhythmias, particularly for AV nodal blockade in conditions like atrial tachycardias, helping to control the heart rate.
Correct. And it's crucial for you as future clinicians to be acutely aware of their adverse events, as these can impact patient compliance and safety.
Side effects. Always important. What's the big one with CCBs?
The most common and often troublesome adverse events for all CCBs, both dihydropyridines and non-dihydropyridines, is pedal edema, swelling in the ankles and feet.
Ankle swelling. Why does that happen?
This isn't true edema in the sense of fluid overload. It's thought to be due to intense vasodilation in the lower extremities, exacerbated by gravity, causing increased capillary pressure and fluid extravasation. It's typically dose-dependent, so higher doses worsen it.
Makes sense.
This often suggests using lower doses or combining CCBs with an ACE inhibitor, or ARB, which can help mitigate the edema by venodilation. Reflex tachycardia is more prominent with short-acting nifedipine due to its rapid BP drop, but verapamil and diltiazem often prevent this due to their direct cardiac effects.
Okay.
Headaches are also a common side effect due to generalized vasodilation, especially early in treatment. And specifically for the non-dihydropyridines, you need to watch for bradycardia and AV nodal blockade, which, while therapeutic for arrhythmias, can be an unwanted side effect for other patients. They can also worsen constipation, a common complaint with verapamil.
Good list to remember. Pedal edema, headache, reflex tachy, DHPs, bradycardia AV, block constipation, non-DHPs. Now let's move on to another powerful class, the direct vasodilators, particularly those that function as nitric oxide donors.
NO donors, right?
Nitric oxide, or NO, is a truly potent physiological dilator of both arterial vascular smooth muscle and venous smooth muscle, making it a critical player in blood pressure regulation.
Yes, physiologically, endogenous NO is produced from the amino acid L-arginine by the enzyme NO synthase, primarily in the endothelial cells. Once formed, NO is a gas that easily diffuses into adjacent smooth muscle cells, where it activates guanylate cyclase, which then produces cyclic GMP.
CGMP pathway, not CMP.
Right, distinct from the cyclic AMP pathway involved in cardiac contractility. Cyclic GMP then causes relaxation of vascular smooth muscle by dephosphorylating myosin light chain, essentially reversing the contraction process. What's fascinating is that NO dilates both arterioles and veins,
Both sides.
both sides. Dilation of arterioles reduces total peripheral resistance, effectively lowering blood pressure. Dilation of veins, however, increases venous capacitance, meaning more blood is held in the periphery and less blood returns to the heart. This reduces intraventricular pressure and myocardial oxygen consumption, which is particularly beneficial in conditions like angina, alleviating symptoms by reducing cardiac workload.
Cool, it helps preload and afterload.
Correct. The problem, as we've discussed, is that endothelial damage in cardiovascular diseases often impairs this crucial endogenous NO production.
Which is where the drugs come in. One key drug in this category, often reserved for critical situations, is sodium nitroprusside. Sounds serious.
It is. This is an incredibly powerful agent with an astonishingly short half-life, around 5 minutes, which means it's only given parenterally, usually as a continuous intravenous infusion.
IV only, very short acting.
It causes an almost immediate and potent drop in blood pressure and a massive increase in venous capacitance because it activates cyclic GMP pathways in both the arterial and venous sides of the circulation.
So when do you use it?
Due to its extreme efficacy and rapid onset, sodium nitroprusside is primarily reserved for hypertensive emergencies and urgencies, and sometimes for stabilizing patients in severe heart failure with high afterload. However, it comes with significant caveats you must know.
Okay, the dangers.
The rapid and dramatic drop in blood pressure can sometimes dangerously activate the reflex sympathetic nervous system, leading to tachycardia. Furthermore, the molecule itself contains cyanide groups and an iron core, which are metabolized by the liver. Patients must have normal liver function for the safe conversion of cyanide to thiocyanate.
Cyanide, okay, that's a big one.
In cases of liver impairment, there's a serious risk of lactic acidosis and cyanide poisoning, making careful monitoring of liver function and acid-base status essential. The critical clinical point is not to drop blood pressure too precipitously, as this can lead to cerebral hyperperfusion in patients with impaired autoregulation, causing brain swelling or hemorrhage.
Drop BP slowly, watch for cyanide. Got it. Another direct vasodilator is hydralazine. How does it compare?
Like sodium nitroprusside, it's also an NO donor. But a crucial distinction for your clinical understanding is that it only acts on the arteriolar side, not the venous side.
Arterial only, okay.
It increases NO, leading to cyclic GMP production, which then causes dephosphorylation of myosin light chain and subsequent vascular smooth muscle relaxation, primarily affecting resistance.
So where is hydralazine used?
Hydralazine is primarily used for hypertension, but it's generally not a first-line drug due to its side effect profile and the need for combination therapy. When given orally, it causes significant sodium and water retention,
The fluid retention problem.
necessitating co-administration with a thiazide diuretic to counteract this. Moreover, because it's such a potent vasodilator, it can cause reflex tachycardia, often requiring a beta blocker to counteract the sympathetic response.
So you need a diuretic and a beta blocker with it.
Often, yes. This often makes it a second or third line agent, typically requiring triple therapy. Hydralazine plus a thiazide plus a beta blocker to manage its compensatory effects. It can also be used in specific cases of heart failure in combination with venodilators, like isosorbide mononitrate, to reduce both afterload and preload.
Okay. Any other big side effects?
A notable adverse event for students to remember is the potential for a drug-induced lupus-like syndrome, an autoimmune condition that requires drug withdrawal.
Lupus-like syndrome. Okay, need to watch for that. Okay, we've covered the fundamental mechanisms, the devastating impact, and now we're starting to fill our toolbox with specific drugs. But the real challenge for you as a medical student is putting it all together in a complex clinical setting. So let's map out the general approach to managing hypertension step by step, like a clinical roadmap.
Good plan. Where do we start?
The first step is absolutely paramount, making a correct and accurate diagnosis of hypertension. This isn't just about getting a number. It requires meticulous attention to blood pressure measurement technique.
Technique matters a lot.
The patient should be seated, relaxed for at least 5 minutes, with their back, feet, and forearm properly supported at heart level. You should take an average of 3 to 5 measurements over a visit. Crucially, hypertension isn't diagnosed on a single elevated reading. It requires sustained elevation, meaning 3 separate consecutive visits over a 1 to 2 month period, unless the initial BP is alarmingly high, like over 160/100 mmHg, which warrants immediate clinical management.
Right, not a one-off reading. And you must also be keenly aware of the white coat effect, where the stress of a clinical setting can falsely elevate blood pressure by about 20 mmHg.
White coat hypertension happens all the time.
It does. In such cases, or if you suspect resistance to therapy or an absence of the normal nocturnal BP dip, which suggests underlying cardiovascular risk, 24-hour ambulatory blood pressure monitoring is invaluable, providing a true picture of a patient's typical blood pressure throughout the day and night. It's often the gold standard for diagnosis.
Ambulatory monitoring, good tool. And for your exams and clinical charting, it's essential to know the specific definitions and severity grades of hypertension. Remind us.
Sure, normal blood pressure is considered less than 120 systolic over 80 diastolic mmHg. Optimal is between 120 129 systolic and less than 80 diastolic. High normal is 130 139 systolic or 80 89 diastolic. Then we hit the diagnostic threshold of 1490.
Okay. 4090 is the cutoff.
Generally, hypertension is graded into 3 levels. Grade 1, mild, is 140 159 systolic or 90 99 diastolic.
Right.
Grade 2, moderate, is 160 179 systolic or 100 109 diastolic. And severe hypertension is greater than or equal to 180 systolic or greater than or equal to 110 diastolic. Isolated systolic hypertension, as we discussed, is a systolic BP equals 140 mmHg, but a diastolic BP 90 mmHg. These classifications guide your management.
Got the grades. Step 2.
The second crucial step, especially for you as future medical students, is to meticulously exclude secondary causes of hypertension. Your management strategy will differ dramatically if a treatable underlying cause is identified. In such cases, the primary goal is to address and ideally remove that cause.
Rule out the fixable stuff first.
Exactly. You should suspect a secondary cause in specific scenarios. Young hypertensives, under 30, those with a sudden onset of high blood pressure, or if they present with specific signs and symptoms, which would then prompt targeted blood tests and special investigations.
Like what kind of signs?
For instance, renovascular hypertension, often due to renal artery stenosis, might present with resistant hypertension and abdominal proteinuria, or unexplained increases in urea and creatinine. Coarctation of the aorta is suspected with a delay between radio and femoral pulses or decreased peripheral pulses. Pheochromocytoma, a rare tumor of the adrenal medulla, manifests with paroxysmal hypertension, high noradrenaline levels, palpitations, high heart rate, flushing, and unexplained sweating.
Pheo, the classic triad.
Right. Conn syndrome, characterized by high aldosterone, presents with sodium water retention, decreased serum potassium, and metabolic alkalosis. Cushing's syndrome, due to excess cortisol, involves increased weight, elevated glucose, sodium water retention, decreased serum potassium, and alkalosis. Other important secondary causes to consider include hyperthyroidism, palpitations, weight loss, liver disease, acromegaly, pregnancy, and the use of oral contraceptives. Always keep these in the back of your mind.
Good checklist. After diagnosing and ruling out secondary causes, step 3 is to identify the presence of target organ damage, or TOD. We talked about how hypertension damages organs.
Right, now we look for evidence. Chronic hypertension, as we detailed in Section 3, silently damages specific vital organs: the kidneys, heart, large blood vessels, and small arteries, arterioles throughout the body.
What are the signs?
For kidneys, signs of damage include decreased urine production, protein or blood in the urine, increased plasma, urea, and creatinine, and peripheral edema. For the heart, you'd look for signs of pulmonary edema, left ventricular hypertrophy on an ECG, which is a common consequence of chronic afterload, or an enlarged heart on X-ray. Damage to large vessels might present as poor peripheral pulses, aneurysms, or brutes. And for small arteries and arterioles, the retinal changes of retinopathy are key indicators, ranging from mild arteriolar narrowing to severe papilledema and directly visible on fundoscopy.
Look for LVH, check urine, listen for brutes, look in the eyes.
Exactly. Identifying TOD is incredibly important because it dictates whether your diagnosis is uncomplicated or complicated hypertension. This distinction profoundly influences your choice of therapy, guiding you towards specific medications that address both the hypertension and the associated comorbidity.
So TOD changes the treatment plan.
Definitely. For example, if a patient has left ventricular hypertrophy, you might prioritize a drug known to regress that hypertrophy. It also impacts the frequency of patient visits and, crucially, how aggressively you need to lower their blood pressure. Patients with TOD typically require more stringent BP targets.
Lower targets if there's damage. Makes sense. Following that TOD assessment, step 4 is to assess the patient's overall cardiovascular risk factors, beyond just the severity of their hypertension.
Look at the whole picture.
Right. You'll consider their smoking status, age, men over 45, women over 55 or with premature menopause, diabetes status, their full lipid profile, high total LDL, low HDL, any family history of premature cardiovascular events, and critically, any previous cardiovascular events they've experienced. Of course, the mere presence of target organ damage itself significantly escalates their overall cardiovascular risk.
The comprehensive assessment of these risk factors is crucial as it directly influences your therapy choice, dictating whether you opt for monotherapy or aggressive combination therapy from the start, and how often the patient needs follow-up visits. Crucially, a higher overall cardiovascular risk means you'll aim for a lower, more aggressive target blood pressure. For instance, a patient with hypertension and diabetes will have a lower target BP than someone with hypertension alone, but no other risk factors.
Tailor the target to the total risk. Finally, step 5. Ensuring blood pressure targets are achieved and maintained at follow-up. This means consistently monitoring blood pressure at each visit. And if targets aren't met, you either change the dose of current medication or add additional medication. It's a dynamic process, not a one-and-done prescription.
Yes, and assessing patient compliance is paramount here, perhaps one of the biggest challenges in chronic disease management. You need to educate them on the importance of regular medication, even if they feel well, and openly address practical issues like cost or medication availability.
Talk about side effects, too.
Absolutely. Always inquire about side effects, as common ones like the dry cough with ACE inhibitors or the pedal edema with CCBs can lead to non-adherence. If side effects are problematic or intolerable, changing the medication is often necessary. Furthermore, at these follow-up visits, you should regularly assess for any increases in overall cardiovascular risk or the development of new target organ damage, as these can evolve over time and require adjustments in therapy or a more aggressive approach to BP lowering. This holistic view is what makes you a good clinician.
Continuous monitoring and adjustment. Got it. Now that we have that clinical roadmap laid out, let's dive into the treatment algorithms themselves, which provide concrete guidance on which therapeutic choices to make. For uncomplicated hypertension, meaning no compelling indications like existing target organ damage, diabetes, or other significant cardiovascular risk factors, what's the target and first step?
For uncomplicated hypertension, the general target is typically below 490 mmHg, though some evidence suggests even lower targets like 30/80 or even 120 systolic for certain patient populations, especially if well tolerated.
That's step 1.
For step 1, in uncomplicated hypertension, especially for mild cases, lifestyle modification is the initial approach for the first few months. This includes dietary changes, increased physical activity, weight loss, and reduced sodium intake. If that's insufficient, or for more severe cases, monotherapy is initiated.
Which drug first?
Your choices are generally a thiazide or thiazide-like diuretic, like hydrochlorothiazide or indapamide, an ACE inhibitor, an angiotensin receptor blocker, ARB, or a calcium channel blocker, CCB. Any of those can be first line. What's fascinating here is that the strongest evidence for monotherapy, especially at a low dose, is actually for a thiazide diuretic.
Thiazide first often has best evidence.
Okay.
What if one drug isn't enough?
If the patient's BP isn't controlled to goal with monotherapy, step 2 involves combining any two of these three primary classes, thiazide, RAAS blocker, or CCB. If still not a goal, step 3 would be to maximize doses, combine all three, or add other medications like aldosterone receptor blockers, spironolactone, or beta blockers. Less commonly used alternative agents for severe or refractory cases include alpha blockers, minoxidil, central-acting drugs, hydralazine, or furosemide.
Okay, stepwise approach. Now, the approach shifts significantly for complicated hypertension, where there are compelling indications, meaning the patient has specific comorbidities or target organ damage.
Right, the choice gets tailored. The rationale here is deeply clinical. You choose an agent that not only effectively treats the hypertension, but also simultaneously addresses the associated comorbidity, essentially killing two birds with one stone and providing comprehensive care.
Which means knowing contraindications is vital.
Absolutely critical for you to know for your exams and for safe practice. For example, thiazide diuretics are generally contraindicated in patients with gout due to their propensity to raise uric acid levels, and they are generally not advisable in pregnancy. Loop diuretics are powerful, but primarily used for fluid overload, and also generally not advisable in pregnancy for hypertension. Anti-aldosterone diuretics like spironolactone are strictly contraindicated in renal failure and hyperkalemia due to the risk of worsening electrolyte imbalance.
Okay.
Dihydropyridine CCBs are generally safe, but require caution in patients with tachyarrhythmias. Non-dihydropyridine CCBs, due to their cardiac effects, are contraindicated in severe AV block or severe heart failure with reduced ejection fraction, and they can exacerbate constipation. RAS blockers, ACI-ARBs, are absolutely contraindicated in pregnancy due to teratogenicity and hyperkalemia and bilateral renal artery stenosis due to risk of acute kidney injury, and they carry a risk of angioedema.
Big warnings for RAS blockers.
Yes. And beta blockers should generally be avoided in asthma COPD due to bronchoconstriction, advanced AV block, pregnancy, uncontrolled diabetes as they can mask hypoglycemia signs and worsen glucose control, severe bradycardia, peripheral vascular disease, and in athletes who need higher heart rates. Knowing these contraindications is essential for patient safety.
Okay, lots of do not use if. So, given these compelling indications, which recommended classes do we prioritize? For angina.
For angina, where chest pain is a primary concern, beta blockers and/or rate-lowering CCBs are the preferred choices because they reduce myocardial oxygen demand. For heart failure was reduced ejection fraction.
HFrEF.
The guideline-directed medical therapy includes loop diazide diuretics to manage fluid overload, specific beta blockers like bisoprolol or carvedilol, and RAS blockers, ACEI, ARB, aldosterone antagonists. Furosemide is specifically used if there's significant congestion or edema. For heart failure with preserved ejection fraction.
HFpEF.
ACE inhibitors or ARBs are first line, with beta blockers as add-ons, and furosemide if there's edema or congestion.
What about after an MI?
For patients with a prior myocardial infarction, beta blockers and/or RAS blockers are strongly recommended choices to prevent recurrent events and improve survival. In diabetes, RAS blockers are highly favored, especially if microalbuminuria is present, due to their profound renal protective effects via efferent vasodilation.
ECZARBs for kidney protection in diabetes.
Right. While CCBs and thiazides can be used, caution is advised as thiazides can worsen hyperglycemia, and beta blockers can mask crucial hypoglycemia signs. For chronic kidney disease, loop diuretics and ACE inhibitors or ARBs are preferred. The latter reduce glomerular filtration pressure and protect the kidney, though, as noted, there's a small but important risk of acute kidney injury in bilateral renal stenosis.
Stroke prevention.
For secondary stroke prevention, low-dose thiazide diuretics, ARBs, or an ACEI plus thiazide combination have demonstrated efficacy. And for peripheral vascular disease, vascular selective CCBs, dihydropyridines, are generally the best class to use as they promote vasodilation without significant cardiac impact.
Very helpful guidelines. Now, what about those tricky cases where blood pressure remains stubbornly high despite your best efforts? Refractory hypertension.
Right. By definition, it means blood pressure remains above the goal target despite the use of 3 different classes of antihypertensives, one of which is typically a diuretic, and often at maximal or near maximal doses.
3 drugs and still not controlled. What do you do?
In such challenging cases, you must systematically explore the underlying causes before considering advanced therapies. Common culprits include improper blood pressure measurement, wrong cuff size, excessive white coat effect, incorrect technique, or pre-measurement factors like caffeine or smoking, which patients might forget to mention.
Check the measurement first.
Always. Non-compliance is also a huge factor, often due to a lack of patient understanding, medication unavailability, or unaddressed side effects. Patients might also be taking other drugs that inadvertently increase BP, like NSAIDs, steroids, estrogen-containing medications, or recreational drugs like cocaine or ecstasy.
Check the med list carefully.
Failed lifestyle modification, such as severe obesity or uncontrolled binge drinking, can also contribute significantly. Another major cause is volume overload, resulting from excessive salt intake, inadequate diuretic therapy, or underlying renal insufficiency. Your management strategy here is to diligently identify and address the specific cause. Only after meticulously ruling out all other possibilities should you then reevaluate for an unsuspected secondary cause of hypertension, which, while rare, can sometimes be uncovered in these refractory cases.
Dig deep for the cause. Okay. Beyond chronic management, you'll also encounter hypertensive urgencies and emergencies, which demand immediate specific interventions and precise clinical judgment. What's the difference?
A hypertensive urgency is defined by a BP of only 110 mmHg or higher, often accompanied by severe headache, nosebleed, shortness of breath, or edema. But critically, there are no immediate life-threatening complications or acute target organ damage.
High BP, symptoms, but no immediate organ threat. How do you manage urgency?
These patients are ideally treated in a hospital setting for observation, though outpatient management can be considered if very stable and close follow-up is assured. The key here is to reduce the diastolic blood pressure to around 100 mmHg slowly, over 48 to 72 hours, to prevent underperfusion of vital organs, especially the brain and kidneys.
Lower BP slowly.
Right. Oral treatment typically involves two agents from classes like long-acting CCBs, low-dose ACE inhibitors, beta blockers, or diuretics. If oral intake isn't possible, intravenous options like sodium nitroprusside or labetalol can be used. In contrast, a hypertensive emergency is defined by a similar blood pressure of 110 mmHg or higher, but with immediate, acute, and life-threatening complications involving target organs.
Emergency high BP plus acute organ damage. These life-threatening complications are absolutely critical for you to memorize and recognize instantly. What are they?
They include unstable angina or acute myocardial infarction, acute left ventricular heart failure with severe pulmonary edema, acute renal failure with encephalopathy, severe retinopathy, grade 3 or 4 indicating papilledema, hemorrhages, exudates, acute aortic dissection or rupture, eclampsia or severe preeclampsia, often after 20 weeks of pregnancy, and hypertensive encephalopathy, characterized by severe headache, visual disturbances, confusion, and even seizures or coma.
Okay, that's a scary list. What about stroke?
In the specific case of acute ischemic stroke, extreme caution is needed. You generally do not lower blood pressure unless the systolic BP is above 220 mmHg or the diastolic BP is above 120 mmHg due to the high risk of aggravating cerebral ischemia by reducing perfusion pressure to an already compromised brain. This is a common test question and a critical clinical decision point.
Don't lower BP too much in acute stroke unless it's extremely high. Got it. How do you manage emergencies?
Management of a hypertensive emergency is always in hospital, ideally in an intensive care unit, with continuous monitoring. Intravenous agents are preferred for rapid and titratable control, such as sodium nitroprusside or labetalol. If IV therapy is unavailable or contraindications exist, specific long-acting oral CCBs or ACE inhibitors may be used with extreme caution. These patients require very close hemodynamic monitoring.
And the goal for lowering BP?
The immediate goal is to decrease the mean arterial pressure by up to 25% within the first 24 hours. And again, this must be done slowly to prevent underperfusion of vital organs.
Slowly, even in an emergency. Tell us about labetalol again.
Labetalol, a beta-1, beta-2, and alpha-1 antagonist, is particularly useful in emergencies because it causes both vasodilation via alpha-1 blockade and negative chronotropinotropy via beta blockade, thereby reducing systemic vascular resistance and protecting the myocardium. It's infusible and has a relatively short half-life, 2 to 4 hours.
And nitroprusside.
Sodium nitroprusside, as we discussed, is another powerful option, known for its very short half-life, 5 minutes, and rapid IV titration, working via cyclic GMP and NO donation. But its rapid action requires careful titration to avoid precipitous drops in BP and related issues like cerebral hyperperfusion or cyanide toxicity and liver dysfunction.
So, to synthesize these critical goals of blood pressure lowering, for uncomplicated hypertension, your target is typically below 2090 mmHg.
Generally, yes.
For high-risk patients, those with diabetes, renal disease, or congestive heart failure, the target is more aggressive, aiming for below 130 mmHg, and you want to achieve this relatively quickly to prevent further organ damage.
Right, tighter control for high risk.
For hypertensive urgencies, the aim is to slowly lower the diastolic pressure to below 100 mmHg over 48 to 72 hours, maintaining cerebral perfusion. And critically, in acute stroke, unless the BP is severely elevated, SBP 220 or DBP 120 mmHg, you generally do not lower blood pressure aggressively to avoid worsening cerebral ischemia.
Key points to remember. Finally, let's talk about effective and acceptable drug combinations, often called polypharmacy. Why combine drugs?
Good question. The rationale here is simple, and it's a core principle of modern pharmacology. It's often better to use 2 or 3 drugs at low concentrations than a single drug at a very high dose. This typically leads to better patient tolerance, fewer dose-dependent side effects, and crucially, synergistic effects, where the combined action is greater than the sum of their individual effects.
Better effects, fewer side effects. Makes sense. What are some really good combos?
Some combinations are particularly effective and truly synergistic, backed by strong evidence. The combination of an ACE inhibitor or an ARB with a dihydropyridine calcium channel blocker, for example, and allopril plus amlodipine, has been shown to synergistically reduce cardiovascular disease. One targets angiotensin II, while the other acts on vascular calcium channels, leading to a powerful combined effect and often mitigating the DHP's pedal edema.
ACE-ARB plus DHP, CCV. Very common. Very good. Another one.
Another excellent combination, frequently available as a fixed-dose pill, is an ACE inhibitor, or ARB, plus a thiazide-like diuretic. Thiazides naturally cause an increase in renin, which paradoxically makes the RAS blockers even more active and potent. This is an especially good combination for secondary stroke prevention and also for patients who need fluid management.
ACEARB plus thiazide. Also very effective. What about other acceptable combinations?
We also have several acceptable combinations that provide additive effects and are used in specific clinical cases. A beta blocker combined with a thiazide, such as bisoprolol plus hydrochlorothiazide, offers additive effects by targeting the heart's beta receptors to reduce cardiac output and heart rate, while the thiazide targets the kidney's fluid regulation and renin system. Similarly, combining a beta blocker with an ACE inhibitor, or ARB, is highly beneficial, especially in patients with ischemic heart disease or stable coronary artery disease, as it significantly reduces MI risk.
Beta blocker combos for heart patients.
Right. A dihydropyridine CCB like amlodipine plus a beta blocker, or example ethanol, can also be used. The CCB primarily targets vascular resistance, and the beta blocker targets cardiac stroke volume and heart rate. While additive, caution is needed with very high CCB doses due to potential SAAV node effects. A CCB plus a thiazide is also an acceptable combination, though with less robust evidence than the synergistic combinations. A thiazide with a potassium-sparing diuretic, like hydrochlorothiazide and amiloride or spironolactone, is commonly used to prevent potassium loss caused by the thiazide.
Good ways to manage potassium. And then there are more complex but still acceptable combinations often reserved for more challenging cases.
Right. For instance, a vasodilator like hydralazine is often combined with a thiazide and a beta blocker. This classic 3-drug regimen is used to counteract hydralazine's side effects of sodium and water retention and reflex sympathetic activation. Similarly, the central acting agent alpha-methyl-dopa, often preferred in pregnancy due to its low teratogenicity risk, tends to cause sodium and water retention, so it's usually given with a thiazide diuretic to manage this.
Okay. Now, it's equally important for both efficacy and patient safety to know which drug combinations are less effective or even potentially dangerous and should be avoided.
Definitely. Which ones are bad news?
Combining a non-dihydropyridine CCB, like verapamil or diltiazem, with the beta blocker is generally contraindicated. Both classes directly target the heart's SAAV node, electrical conduction, and contractility. Using them together results in overlapping cardiac toxicity, leading to severe bradycardia, AV block, and can dangerously reduce cardiac output.
Non-DHP plus beta blocker includes big no-no.
Big no-no. Another combination to use with extreme caution, if at all, is alpha-methyl-dopa plus a beta blocker. Both significantly reduce sympathetic tone, leading to an overwhelming decrease that can also severely depress cardiac output and cause profound hypotension.
Okay, watch out for that one too. And then there are the combinations that should be absolutely avoided because they offer no improved clinical benefit and only significantly increase adverse events.
They're really bad ideas.
The most prominent example, definitively shown in the ON-Target trial, is combining an ACE inhibitor with an ARB. This dual RAS blockade showed no improved cardiovascular outcomes, only increased adverse effects like hyperkalemia and renal dysfunction.
ACE plus ARB consists in.
Clear evidence against it.
Similarly, combining a non-dihydropyridine CCB with the dihydropyridine CCB is poorly tolerated and potentially toxic due to excessive vasodilation and subsequent reflex sympathetic activation without added benefit. And as a general pharmacological rule, it makes no kinetic or dynamic sense to use 2 ACE inhibitors, 2 ARBs, or 2 beta blockers simultaneously, as they generally target the same pathways and receptors. These combinations offer no additional benefit and should be avoided in practice.
Don't double up within the same specific class mechanism. Makes sense.
Wow, what a journey through the intricate world of hypertension. We've taken a really deep dive, starting from the critical physiological mechanisms that normally control your blood pressure, then journeyed through the multifaceted and often devastating damage that sustained high blood pressure inflicts on target organs throughout the body. And we've also navigated the nuanced, evidence-based pharmacological strategies for its management. You now have, hopefully, a comprehensive understanding not only of what these drugs do, but critically, why they are chosen based on their precise mechanisms of action and the specific clinical context, including the importance of appropriate synergistic combinations.
Yeah.
This deep dive should arm you with the comprehensive knowledge necessary not just for acing your exams, but for making truly informed, life-saving clinical decisions in your future practice. Remember, hypertension really is a vicious cycle, and your informed intervention is paramount to breaking it.
That's a powerful call to action. And to leave you with a final thought as you continue your studies, given the incredible complexity of hypertensive disease with its various presentations and the vast array of pharmacological options we currently have, what might be the next frontier in antihypertensive therapy?
Good question to ponder.
What novel targets or diagnostic approaches could truly break the vicious cycle and prevent end organ damage in ways we can't yet imagine with our current drug classes? Keep that curiosity alive as you step into the clinical world, because the answers to those questions will shape the future of medicine.